Okay, thank you to all my patients, surgeons, no disclosures here. And coming to the definition of supraglottic airway device. These are the airway devices that sits over the glottis. Now this, and hence it is, okay, and hence it is supraglottic. It's also called as the extraglottic or a laryngeal mask airway, because a mask from over your face, no face mask just directly goes on, sits over the glottis or the larynx. That's why it's called a laryngeal mask airway. It allows you to have an open airway, a secure and sealed airway, to provide an unobstructed airway path in a spontaneous or a ventilated patients, during mainly used during anesthesia and can be used in the ICCU also. Okay. Now we'll come to the development. I mean, first when it was developed by in 1981 by Archie Brain. Okay, it was the first LMA classic. In 1983, he got the approval of and the first case of airway rescue, and many companies have turned him down before this. No, he kept on developing, making changes in the, and then he approached the Dunlop company, which makes the tires, rubber company, you know. And in 1984, they developed the first Dunlop prototype that was in the black rubber LMA. Okay, and the first case of all factory-made LMA classics came out in the on 5th December 1987. And by 1988 to 1991, it was introduced and it flooded the market. And first time LMA or SGD was included in the American Society of Airway for Difficult Airway Algorithm for in 1993. So what is the classic LMA? Okay, so in the classic LMA, you will see, I have it with me. Okay, so this is a classic LMA. Okay, you have an aperture bar inside. There is a cuff, okay, and a airway tube. This is a 15 connector which gets connected to your ventilating circuit or the umbu bag. There is an inflation one-way valve, an inflation pilot balloon, an inflation line around here. Okay, so when you are, you can see that this was the initial, and there was no, in the sense, there was a continuous similar line of cuff airway. Okay, you can see that, and there were aperture bars here to prevent the epiglottis from falling into the bowl of the SGD and causing obstruction to the airway path. Now, what were the limitations of this classic LMA? It cannot isolate the airway. It is sitting on the esophagus and the trachea, that is the glottis opening. So, in effect, it is sitting on both. So, it's not isolating the airway from the gastric channel. Okay, that is esophagus. Therefore, increased risk of aspiration was present. And because it has no intrinsic design, the cuff is a continuous same length line, you know. So it could not withstand airway pressures of more than 20 centimeters of water. What happens is, when the pressure increases above 20, it gets thrown above. Okay, so there is a leak in the pericuff leak. So ineffective, there is less effective ventilation. Okay, and hence there was, see, it's a continuous tube with the cuff not withstanding an airway pressure. So what will happen is, this will become malpositions, and there is no separate port for gastric or suction port where we can directly address the gastric secretions. Okay, and it needed more efforts for insertion. Why? Because this had to be, you had to put the index finger in the slot between the cuff and the airway tube and slide along the hard palate, reach the soft palate, and then push it on the glottic region. So you needed more effort. The airway tube was not preformed according to the airway pathway. So you needed expertise, you needed help, you needed another hand also. Plus, there was no bite block at the proximal end. So if the patient bites, it can cause obstruction. Okay. Now, to address this, they developed LMA flexible, which had a flexible flexometallic kind of airway tube. Okay, but still the in that is in 1990, but still it could not withstand airway pressures above 20 centimeters or more. But and it was thrown off from the glottic area. Okay, when the airway pressures increased, like in when the patient was coughing or the patient was fighting the tube or something. So then for that they developed like a seal. So here you can see that there was a reinforced over the tube at this part. Okay, it had made it rigid so that it remains in the place. And they developed an cuff pressure monitoring. What happened if there is a leak, we used to start inflating the cuff more and more. It used to cause lateral pressure changes and damages, and patient could get stridor post-op. So in order to monitor that, they integrated a cuff pressure monitor in the one-way valve of the pilot balloon itself. Okay, that is LMA Suar series. And in 1997, they developed a disposable one, that is LMA Unique and LMA Unique Evo. Now, what is that? LMA Unique Evo was the first generation LMA to support the fiber optic because of the aperture bars here. Okay, the LMA Classic, the LMA Unique, LMA Swashield and the Flexible could not allow the fiber optic to pass. Though you can, but then you couldn't intubate through it. Okay, so or you needed a very smaller endotracheal tube. So in order to develop that, LMA Unique Evo was the first generation to support fiber optic bronchoscopic intubation up to an endotracheal tube of around 7 and 8. It has an integrated cuff pressure monitor around here. It lowers the risk of sore throat because of the silicone cuff, and it has a soft, flexible curve of the airway. Now, if you will notice difference between LMA Unique Evo and LMA Unique, you will see this has a long airway tube. You have to note given it is made for intubating, passing helping intubation or passing a fiber optic scope, then the airway tube becomes shorter. Okay, in subsequent LMAs also you'll see that was the development for allowing intubation through the supraglottic device. Okay, it has an integrated bite block too. Okay, to prevent damage because of, but still these were all first generation. Now what later LME proseal was developed in 2000. This is LME proseal, you can see. Okay, so now what, it has a inflation pilot balloon similar to your classic, but it has a manual vent deflating also. This is for storage purposes. It keeps in a functional way because this was reusable, could be autoclaved 40 times. So if the rubber gets stuck to each other, okay, it can get damaged while storing. So the manual vent allowed air to enter in between, and it was supple enough, but not so much so that it would cause burst also, the air with air expansion.